other people are going to use
He's the Edwin Dixon Professor of Pediatrics and the Division Director of Neonatology at UAB. Many of you know Wally really well, as he has been involved in multiple NIH-funded network studies, including the Global Network for Women's and Children's Health Research and the Neonatal Research Network. He has developed innovative devices, including a high-frequency ventilator, a flow interrupter, to perform pulmonary function testing, and a low-cost oxygen air blender. So neonatal lungs, if you have to look clinical, Wally is the one to look up to. His primary focus is on reducing mortality and major morbidities during early childhood in the US, and he has done extensive amount of studies all over the world to reduce childhood mortality. And since I've trained under both Dr. Poindexter and Wally, I could clearly say this is going to be a really good session today.
And Dr. Carlo will briefly introduce Dr. John Tyson, who's one of the authors on the paper. Thank you.
Thank you, Sai. And I'm so pleased that we have Dr. Tyson on the call today. He's professor of pediatrics at UT Houston. He was the lead author of the clinical trial that we will be discussing. He has been a lead author of many important manuscripts. He has been honored with the highest award in neonatology, the Virginia Apgar Award. It is so good to have Dr. Tyson here. He is an expert in clinical trials, so his insight will be very important.
Thank you so much, Dr. Carlo, for that introduction. And thank you, Dr. Poindexter, Dr. Carlo, and Dr. Campbell, and Dr. Tyson for helping us all learn more about this trial. In order to just understand baseline rates of use of vitamin A in your units and make this discussion even more interactive, we've created a poll. While Dr. Campbell will start sharing her slides, I'm going to launch a poll. Everyone can answer this poll using your computer, and I will share the answers right after you're all done answering. We have about 22 responses so far. Another 10 seconds before I end the poll and publish the results. Hopefully you all can see the poll results. The first question was, does your unit currently administer vitamin A to ELBW infants? It was 47% said yes and 53% said no. What is the baseline rate of death or BPD? What the baseline rate of death or BPD at your institution in comparison to the study? Similar rates was the most popular answer. What dose of vitamin A does your practice use in ELBW infants? Looks like 41%, the majority, is using a 5,000 international units, IM 3 times a week for the first 4 weeks. I will stop sharing and I'll hand the presentation over to Dr. Campbell.
Thank you. As mentioned, I'm a third-year neonatology fellow at Vanderbilt, and I've had so much fun putting this presentation together. I'm excited to hear everyone's perspective from the audience members, so anyone in different stages in their career, our moderators, and even Dr. Tyson himself. But especially interested in learning the history of vitamin A over time and how it's progressed over the years, especially through the shortage. So to start out, I wanted to provide a historical perspective for the trainees in the audience and the early career neonatologists. So the development of vitamin A therapy for preterm infants actually began with the observation that the histologic appearance of the lungs for vitamin A deficient rodents resembled that of infants who had BPD. And this is a photo courtesy of a paper provided by Millie Stallman, who was instrumental in this work along with Jay Chennai at Vanderbilt. And in the panel to the left, it's actually from 1925, and it shows that the tracheal epithelium of a vitamin A deficient rodent resembles the tracheal epithelium of an infant who was 880 grams, 27 weeks gestation, and ended up passing away at 5 months from BPD. And the thought behind vitamin A is that vitamin A deficiency may promote chronic lung disease by multiple ways, impairing lung healing, increasing loss of the cilia, increasing squamous cell metaplasia, increasing susceptibility to infection, and increasing the number of alveoli. And decreasing the number of alveoli when you're deficient in vitamin A. And subsequent studies have demonstrated that lung lesions seen in vitamin A deficient rodents could be reversed by supplying vitamin A to deficient animals. And it's that type of study that set the stage for the first clinical trial in the late 1980s by Dr. Jay Chennai and Millie Stallman. just to put it simply, I mean, when you compare the term infant to the majority of very low birth weight infants, the infants born at a lower weight have generalized deficiency in vitamin A and its binding protein, which is retinol binding protein. And in the figure to the right, it's from the 1987 study, but it shows that intramuscular vitamin A supplementation to infants born at low birth weights allowed for normalization of plasma levels of vitamin A, which is seen in the top panel, and normal levels of plasma retinol binding protein shown in the bottom panel. But it's this IM injection that's, I think, is the key. There's poor enteral absorption of vitamin A, and IV forms of vitamin A in crystalloid solutions is unreliable. So really the history of the development of vitamin A therapy is a nice example of in neonatology of bench to bedside scientific adventure. And really there were decades of research studies in animals, and it was all based on the idea that if you give this biologically plausible, inexpensive, and fairly simple intervention, vitamin A, it could have a favorable impact for our infants who have BPD. So there's a significant amount of clinical research in this area. And today we get to talk about Dr. Tyson's 1999 RCT, which to date is still the largest trial ever done on this subject. And with a sample size of 807 infants, it's more than 5 times the sample size of any of the next largest trials. So Dr. Tyson, we're really excited to hear your opinion throughout this talk. As an overview of your study, it was based on the hypothesis that vitamin A supplementation would increase the rate of survival without chronic lung disease and potentially reduce hospital-acquired sepsis. So you performed a multi-centered, blinded, randomized controlled trial. It had a parallel design to study the safety and effectiveness of a higher dose of vitamin A than that used in previous trials for extremely low birth weight infants. Again, you had 807 infants, and they were within a birth weight range of 401 and 1,000 grams. They were required to be on either supplemental oxygen or mechanically ventilated at 24 hours of life. All of the centers in this study were hospitals who participated in the NICHD neonatal network. So all were US based. And it was from 1996 to 1997. There were 2 arms in the study. So you have your intervention group with 405 babies receiving intramuscular vitamin A, 5,000 international units, 0.1 ml, and it's given on Monday, Wednesday, Fridays for the first 4 weeks. All infants, no matter what their birth weight, received that same dose. And then in the control arm, 402 babies, there was a sham procedure rather than placebo injection. For the primary outcome, it was a composite outcome looking at oxygen requirement or death at 36 weeks post-menstrual age. And then for hypothesis generating secondary outcomes, we looked at oxygen requirement or death at 28 days of life, culture proven sepsis, grade 3 or 4 IVH, periventricular leukomalacia. There was also a subset of babies who on study day 28, we looked at vitamin A levels and relative dose response to 2,000 international units of vitamin A. All babies also were examined weekly for any potential toxicity. We mentioned the inclusion criteria earlier, but to be excluded, you had to have a major congenital anomaly, any sort of infection, a congenital non-bacterial infection, or terminal illness, which was indicated if the pH was less than 6.8, or if there was any presence of hypoxia with bradycardia for more than 2 hours. Infants were enrolled between 24 and 96 hours of life, and the study team performed a stratified randomization in order to prevent any imbalance between your vitamin A group and your control group for factors that might influence your treatment responsiveness. And so they stratified based on center and birth weight, which are two key covariables associated with the outcome BPD. For allocation concealment, infants were assigned to either vitamin A or the control group by a hospital pharmacist using a randomization list. And then at 4 centers, the research nurse used sealed envelopes containing the treatment assignments. So there was triple masking with the participant, care provider, and outcomes assessor all masked. Now, it was a little bit unclear how the generation of random sequence was made, whether or not that was simple random allocation with a random number table or a computer software program, or whether or not permuted block randomization was used. And perhaps we can talk about that either now or later on.
Dr. Campbell,
Yes.
Just with the dosing of 5,000 international units of vitamin A, how did Dr. Tyson or Dr. Carlo or Dr. Poindexter, how did we come up with that dose, and why did we, was it more of a dose establishing study initially when we designed the study, or based on the previous studies which were published around 2,000 international units?
So I'll try to answer that. Kathleen Kennedy, who had been a fellow at the time with Jay Chennai, and I agreed that before we should do a vitamin A trial, that we needed to do a dose finding study based on what we thought was the desirable blood levels. And that to this day, I think that's a debatable issue of what are the desirable blood levels. But it was selected based on a study done at Vanderbilt based on their work and later work looking at the actual blood levels on different dosing. It was a randomized pilot study. So, so it was, I think, about as good as we could do. And I think it is something that should be more often done in neonatology when we decide what dose of antibiotics we're going to give, or as I would now argue with phototherapy, what dose of phototherapy we're going to give. So, okay. And by the way, y'all refer to it as my study. There are lots of people deserve credit for this.
Thank you. Dr. Campbell?
Okay. In terms of blinding, to avoid pain, there was the sham procedure done rather than placebo injections. And for each treatment, a screen was placed around the bed of the baby. A pacifier was used to minimize crying, and any sort of injection was covered with an adhesive bandage, even if you were in the control group. Outcomes were assessed by research nurses that then transmitted data electronically to a biostatistical coordinating center.
I just have a quick poll regarding the blinding randomization, how it was done on the study, and Dr. Poindexter will add an important point that when she was participating in the study, found out. So participants can respond to the poll just like you did for the previous one. Five seconds before I end the poll. Great. I will share the results. Looks like 36% felt it was very effective. 58% felt it was effective. 6% or 2 of us felt it was not effective. But Dr. Poindexter had an important learning from a historical perspective for.
At the risk of making John feel old, I was a fellow at the time this study was being conducted, and I vividly remember a mother telling me that the vitamin A had cured her baby's lung disease, and when I asked her how she knew that her baby was receiving vitamin A, she said, well, how do you think? I lifted up the Band-Aid to see if there was blood on the, cotton part of the Band-Aid. So I think the learning pearl is that the mothers of our babies are often a lot smarter than we are. But I do think that the blinding procedure was as well designed as possibly could have been done, and doubt that we had too many mothers that were lifting up the Band-Aid, but who knows?
I agree with
hadn't heard
Dr.
that. Thank you.
Poindexter. I thought it was well done, except for those rare occasions. The nurses, for example, and the physician were very good about knowing they could not remove the Band-Aid. The Band-Aid was placed behind a screen, so none of the caretakers knew anything about it. I don't want to date myself, but I wasn't attending then, and I remember asking my attendings if they knew which baby got what, and they said no, I have no idea. So I think it was pretty good. The nitric oxide was done in a similar way with, let's say an imperfect masking, but because obviously we will not give a shot of normal saline or something intramuscularly to make the blinding, but it's as good as it can be done, as Dr. Poindexter concluded.
And I'm not sure that as we have done, subsequent clinical trials, that we have built into our study design any attempts to ascertain how effective blinding or masking is. I don't know, John, if you have thoughts, if that's something that would be important to do in designing a study, or?
I've been reluctant to do that because I thought it would encourage people to try and figure it out. No, yeah. So in terms of the procedure used, actually, we were reluctant to do anything that would cause pain, partly because the previous IVIG study had been stopped for the suspicion that it increased the risk of necrotizing enterocolitis in the placebo group. And there was reason to think maybe if you do something that causes pain repeatedly, that you might increase catecholamines, reduce GI blood flow. And that's been a concern with vitamin A intramuscular. But a fortunate thing about this study design is that we saw no evidence that the combination of the pain of the stick plus the vitamin A increased any secondary outcomes as well with PVL, IVH, NEC. So
just
Okay.
piggybacking on that, Dr. Tyson, while designing the study, was there any hesitancy amongst neonatologists about 3 IM injections weekly for almost 4 weeks? Like, what were some of those discussions behind giving IM injections to our very low birth weight infants, and what kind of hurdles did you have to come through to make this happen?
I honestly don't remember any objection to the study based on that because of concerns about IVH, and it was the small volume that was given. I remember one of the research nurses at Providence, Rhode Island, Angelita Hensman, actually called me up and said, I think we ought to use a smaller needle. But among the physicians, I don't remember it being discussed. One of the two important things about this study that wish I had done differently would have been to record the number of skin punctures, because as you know, as will be presented, I thought very seriously about having two primary outcomes: infection and chronic lung disease. But the statistician said, well, if you had infection, we're going to make you get a P less than 0.025. And I wasn't quite as confident about infection. And you see the relative risk of that was 0.91. But it's entirely possible if we had recorded the number of skin punctures for including everything like sepsis workups, antibiotics, whatever, that it's not necessarily a given that the vitamin A group would have had more painful procedures. That's kind of been assumed in the discussions by people who don't want to use vitamin A, but I think that's uncertain.
Thank you so much. Dr. Campbell.
Great discussion. The study coordinators, or not the study coordinators, the study team used an intention to treat analysis, which is always the right choice to make. And then depending on whether or not their variable is continuous, categorical, dichotomous, parametric versus non-parametric, they chose to use a student's t-test, Wilcoxon ranked sum test, chi-square, or Fisher exact test. The primary outcome was adjusted, as we said, for center and birth weight, and that was analyzed with the Mantle-Hazel analysis. And then there was an independent data and safety monitoring committee, which was appointed by the NICHD group, and they reviewed any adverse events. There was one interim analysis performed, and then I did not see anywhere in the paper that the sample size calculation was specified. Dr. Tyson, was that previously done in a different paper, or do you remember?
The New England Journal, as I remember, made me get it down to 2,700 words, and they took it out. I mean, to try and describe this study in 2,700 words was really tough. It was done. I can't remember the details of it now.
Okay.
But I remember fighting with them about that.
Good to know. Okay, so of the 1,993 extremely low birth weight infants who were screened for enrollment, the top group were ineligible. So 448 were considered terminally ill, and then 241 just weren't on oxygen or mechanical ventilation at the 24-hour of life time point. And then in that bottom group, the rest were just not enrolled either because of parental refusal, unable to consent, maybe the parent wasn't at the bedside to consent them, or 27 had physician refusal.
Meredith, if I can just make a comment. I mean, I think this is an exceptionally high rate of parental consent. And over the past decade, you know, within the Neonatal Research Network and with other large multi-center trials, I think the anticipated rate of parental consent has really gone down. I think I think that's about, you know, 65–70% consent rate. And we would be over the moon if we were anywhere close to that in a contemporary trial. I don't have an exact reason for why, you know, our consent rates seem to have declined over the years, but I think this was a really remarkable effort, you know, by the research coordinators at each of the sites.
It's a really good point.
And Dr. Campbell, was there any information provided on what terminally ill, like how they defined that particular population? Because it seemed like a significant chunk of those patients, if they were just too sick to enroll, or can you elaborate on that, please?
All I could find is kind of what was stated in those exclusion criteria of you needed a pH less than 6.8 or hypoxia plus bradycardia for 2 hours. But there were no sort of listed congenital anomalies or diagnoses that I could find.
Thank you.
Yeah. Moving on to table 1, we have the nice baseline characteristics of all the events. And when you compare the two study groups, they're really quite similar. So, I mean, very, very similar. So birth weights were pretty much spot on at around 770 grams. Gestational age was very close to 26 weeks and some change. About 50% of the study participants were African-American, and really looking through all of the ethnicities, everything was comparable. Even for antenatal glucocorticoid therapy, about 74, 76 received it between the two groups. And then there was also really no difference between the type of delivery room care infants were receiving in each group, surfactant administration, respiratory status at 24 hours of life, or even their baseline serum retinol levels. Everything was really close. I will move
So
on.
Dr. Campbell, why
Yeah.
are there not p-values in that table?
Yeah, so generally for randomized control studies, you do not include p-values because you're really assessing, was your randomization and allocation concealment, was your blinding all well done? So you're kind of looking, well, that would prevent any bias in your outcomes. And so it's really kind of looking where the groups randomized well. And I think the fact that you stratified by birth weight probably explains why that birth weight was so similar between the groups. Go ahead, Dr. Tyson, I think.
So whatever difference you see, unless somebody lied about whether the babies were randomized, whatever difference you see necessarily is due to chance. So it's not meaningful to calculate a p-value to estimate the likelihood that the difference occurred by chance. Right? Okay.
Perfect.
Wally,
And I have argued with New England Journal editors about that issue.
so Wally, you may point out, so from the support trial, what was the incubation rate in this group of babies? And do you think seems like the rate is higher would influence the outcomes if we repeat this trial these days?
Yeah, in the intervention group, so we try not to intubate. It was about 2/3 of the patients got intubated.
Okay. So do you think the higher is, if we repeat the same trial with the current lower intubation rate, more CPAP, are we going to see different results or anything?
I think the results of the vitamin A are probably still pertinent today because even the study sites, and this is not published, but the study sites with the low incidence of BPD also had a benefit with vitamin A.
Okay.
Certainly I think our practices are different. I mean, we no longer intubate 90% of these babies. And, I think even the rate of antenatal steroids is lower than what we would find, in most of our centers. And then, remember, no babies less than 24 weeks were included. And, those are the babies that I think most of us are still struggling to, manage effectively and probably have the highest rate of BPD.
Thank you.
And I would highlight, Vera, that this study included babies down to 401 grams, and this is back in the 90s. So this was a very high risk population then when intubation was also commonly practiced early. So it's remarkable that this study was included such small babies.
I'm going to move on to figure 1, which essentially shows that control and study infants received similar intakes of vitamin A from other sources other than our 5,000 international units of IM injection. And they kind of color coordinated to show how much vitamin A was estimated to be from an enteral source versus an IV source. I also want to point out that in the vitamin A group, that group received 99% of its intended doses.
Dr. Poindexter, do you want to comment on the feeding practices around the time of this trial? As we all know that's another area we've evolved and changed significantly, please.
Yeah, absolutely. I think, at the time that this was conducted, we were just starting to understand the importance of early parenteral nutrition. But at that point, a lot of it was more just thinking about getting amino acids started. And I think there was less emphasis on early enteral nutrition and certainly on early fortification of human milk, where I think, you know, the enteral supply then of vitamins would be impacted. You know, and just thinking about the solubility of fat soluble vitamins like vitamin A, and how different centers were even administering interlipids when those were starting. Were they given in combination with the rest of the parenteral nutrition with the multivitamins or not? And so I think there was, you know, probably greater variability between the centers. And I don't know if Meredith's going to show this, but some of the, you know, the measurements of the vitamin A levels across different centers in this study were pretty fascinating.
Thank you. Dr. Campbell.
So table 2, we can see that our primary composite outcome is listed in that first row. So chronic lung disease or death by 36 weeks post-menstrual age. And in the vitamin A group, there was a lower rate of this, 55% compared to 62%. The relative risk is 0.89 with the confidence interval of 0.8 to 0.99 and p-value of 0.03. And then I also show that when you kind of take out the composite variables separately, death by 36 weeks gestation was not significant. Survival with chronic lung disease at 36 weeks gestation did have a relative risk of 0.85, confidence interval 0.73 to 0.98, and then a p-value of 0.03. So overall, 1 additional infant survived without chronic lung disease for every 14 to 15 infants who received vitamin A supplementation, which I think seems pretty impressive. What do the moderators agree?
Yes, I certainly agree. Bronchopulmonary dysplasia is one of those morbidities that have been most difficult to bring down. And this study had a large benefit.
Mm-hmm.
I think especially if you think about all of the various interventions that we try, and you think about, you know, this study wasn't designed to evaluate a composite of different interventions, but I think, you know, to really make a reduction in BPD, I think we all recognize it really takes a multifactorial approach. So for one simple intervention to have such a dramatic effect, I think is really, really important, and probably highlights why you all chose to review this article in this forum.
So the New England Journal editors inserted the word modest or modestly in the abstract, which I only learned about at the galley proof stage and was unsuccessful in getting them to change it. But when I talked with the editor, I said, hey, I read articles in your journal that say we should use statins and we should use aspirin and we should do other interventions when the number needed to treat is in the hundreds. And it's not for 4 weeks, it's for years. And he said, well, you have a point, but it's too late. It's being printed. So I've done, you know, there are not many therapies that the network has tested. I mean, hypothermia had, I think, as I remember, number needed to treat of 6 or something. But that's a good number needed to treat across all therapies in all age groups.
I agree with Dr. Tyson, and just a commentary to the participants. The editors sometimes are real tough, the reviewers are real tough, and many times they're wrong. So actually the paper sometimes says things like this example of a moderate effect that would be really considered like the best treatment to prevent BPD right now, or at the time at least. But the effect size is very large. If you think of other potential therapies for, as Dr. Poindexter highlighted, for this complex disease that is multifactorial.
Great points, Dr. Campbell.
So we're just continuing to go down table 2 right now. This first section, it's the first 2 rows are actually auction at 36 weeks post-menstrual age, but there was no difference for mechanical ventilation needs at 36 weeks gestation. I would highlight that vitamin A was associated with non-significant trends towards reduced risks for sepsis with a relative risk of 0.91, intracranial hemorrhage with a relative risk of 0.93, and then periventricular leukomalacia at 0.74. Were there any other secondary outcomes on this slide that anyone wants to point out or discuss? No, okay. I'm going to move on to.
So do y'all
Okay.
talk about frequentist versus Bayesian statistics on these? Have y'all talked about that in these journal clubs? So to point out, so the American Statistical Association has published a paper saying that a p-value, there should be no p-value threshold for scientific decision making. So they wouldn't advocate using p less than 0.05 or any other particular value. And so if I had said, okay, to the statisticians, let's make infection of sepsis a secondary, not a secondary outcome, a primary outcome, and imagine 2 parallel universes in which 2 investigators did exactly the same thing, got exactly the same results. And the frequentist statistician said, well, to be significant with 2 outcomes, it's got to be less than 0.025. In one paper, they would say no effect. And in the other, with 1 outcome, they say there is an effect. That's pretty bizarre, don't you think? That kind of arbitrary thinking should determine all or none recommendations when we really want more nuanced recommendations, which Bayesian statistics allows you to estimate the probability of benefit for treatments, which is different, of course, than the p-value. With p-value, and we can talk about that more if anybody wants to. Brenda and Wally are sick of hearing me talk about Bayesian statistics.
I agree, John, and I think people are still stuck on the p-value of 0.05 and do not consider Bayesian analysis.
I'm going to move to, oh, go ahead.
No,
Okay.
go ahead.
I'm going to move to table 3. So this shows, well, really the first 300 subjects had measurements of their serum vitamin A levels and retinoid dose response testing, which is essentially what this shows. And so those in the vitamin A group, the serum concentrations of retinol binding protein, and retinol esters were higher compared to control. And then they also put subgroups under each of these vitamin A levels, looking at whether or not postnatal glucogotherapy was given. And they were specifically, I think, thinking about postnatal dexamethasone treatment, which can cause a short-term increase in plasma concentration levels. So kind of higher risk for the thought of being toxicity.
Well, is it toxicity? Well, so how do you interpret those high levels? How do we get high levels? So you mobilize vitamin A from the liver. And at least at the time I read about this and knew about it, also from the lung. And so you may have high blood levels at the expense of low tissue levels. So it gets really hard to know how to interpret those levels. And earlier you mentioned the phrase normal vitamin A levels. So that word normal, I think, is a word that we use that confuses rather than clarifies many of our discussions. Because if I ask a number of y'all what you mean by the word normal, my guess is there'd be a lot of difference in what people said. In the literature, you see some people that say normal is a statistical definition, what's ever between one, say the 5th percentile and the 95th, or the 3rd and the 97th. So they were defining normal in terms of what's common and abnormal in terms of what's uncommon. Other people do it based on risk factors. Is a risk factor, is a low vitamin A risk factor for BPD? And that doesn't necessarily mean it's a cause of BPD. Some people think it's abnormal if it actually causes BPD. And then you can go one step further and say, well, you should define abnormal in whatever, in any value that you can treat and make the patient better. So risk factor, frequency, statistical definition, causation, or treatment, all of those things appear in the literature. So if you're going to use that word, you want to make sure you really understand what it means and what kind of population it was drawn from.
It's a really good point.
So I don't know what normal retinol levels should be.
And I also have a question to our faculty mentors. At least from this table, we can see that the rates of postnatal glucocorticoid therapy is higher in the vitamin A group, at least with the evidence that's available on dexamethasone use postnatally may facilitate extubation in our neonates. Like, has that been adjusted when we're looking at the primary outcome of death or BPD in this particular study at all? The use of postnatal glucocorticoid therapy, was the outcome adjusted for that?
Would you want to adjust for that? It's an event that occurs after randomization. Maybe that's an effect measure. That's an outcome variable, whether or not more steroids were given or less steroids were given. So in most studies, it's a no-no to adjust for events or findings after randomization.
The next 3 slides really review the Consort 2010 checklist, which I realize that's after 1999. I thought you guys did a really good job filling the boxes for most of these things. We discussed how the sample size was left out because of certain criteria with the New England Journal of Medicine. And then there perhaps could have been a little bit more information on how random allocation sequence was generated and whether or not block sizes were used. And then I didn't take off many points for this because in 2010, you guys added your study to clinicaltrials.gov.
As Dr. Tyson mentioned, sometimes like the editors say, can you reduce all the blinding, masking, all of that? Can you reduce it to one sentence? And then it becomes very hard to specify every single thing. So yeah, I think sometimes we cannot be so explicit with every detail, but one can also look back at the protocol. So that's something that is happening now, that most trials now, or most journals now, publish the protocol itself, which has many more details, and that's in the as a supplementary material of the article.
Perfect. These 3 questions are in place mainly to generate discussion among the audience and the moderators and Dr. Tyson. So just kind of thinking about generalizability of the study, whether or not it's feasible to implement vitamin A in individual NICUs, and then weighing the potential benefit versus the potential harm of giving vitamin A.
Meredith, I may be getting a little bit ahead, but were you going to speak to feasibility in terms of, the timing of after this paper was published, and then there was really a national shortage of availability of the product?
Yes, and let's just jump. I think it's 2 slides or so.
Oh, I mean, we can, pause for that discussion, but I just wanted to make
Yeah.
sure.
Well, I think it's a good discussion. So I think in 2011, there was a national shortage of vitamin A supplementation. And so I wanted to just kind of mention this slide from Tolia, and Reese Clark was on this paper as well. It's a retrospective cohort study in which the authors replicated inclusion criteria for the vitamin A trial, the 1999 New England Journal one we were talking about. So they included infants less than 1,000 grams and infants who were on either supplemental oxygen or mechanical ventilation at 24 hours of life. And what's interesting is that even in their centers who had high use of vitamin A supplementation, so 75 to 100% of infants who met criteria for vitamin A were getting it before the shortage. Despite that, after the shortage, there was really no increase in death or chronic lung disease once vitamin A was unavailable in those centers. And so one would expect that there would be an increase in incidence among, for bronchopulmonary dysplasia or death. The study authors did bring up, perhaps other interventions or practices were being put in place during this time. So changes to non-invasive ventilation or changes to our oxygen saturations. But I think that it's important for us to remember that this is, a retrospective cohort study, and I think it's you can't compare it to a randomized controlled trial.
That's a good point, and to highlight that the support paper was published in 2010, the second quarter. So as you said, there may have been changes in practices. There's a paper that will be published soon that will show the major changes in practices following around this time. So there were changes in reduction in non-invasive ventilation.
And Wally, I don't recall, I know that now we track in the generic database which infants receive vitamin A as an intervention. But after this study was published, I think we went several years without really keeping close tabs on how many centers were actually implementing the therapy. And I think, probably with a lot of the studies you all are looking at this year, there's this delay between when a pivotal trial is published and when you actually have, the uptake that you would think you would be seeing. And, I don't know that I fully understand what is it that takes us so long to be convinced enough to change practice. And I don't know, John, are you aware of, the timing of right after the study was published of how widely vitamin A was adopted?
Linda Wright at NICHD asked me to determine that. And I said, Linda, that is beyond reasonable. I can't get people to provide that information. But there was this guy called Wally Carlo who did that. Wally, you want to tell us the results? And as I recall, you got an astonishing, 97% or something like that of neonatal units to respond to you?
That's right. Yes, we got a very high percentage of neonatal units to respond. And at the time, it was about 20%. But the good thing I saw today, the survey, half of the people on this call are using vitamin A in their units.
Yes.
So that's the highest I've seen. It takes time. It takes time until there are meta-analysis, for example, or maybe changes in recommendation by professional groups or leading authors who write in support, and then gradually people adopt. But yeah, it's interesting how, as Brenda said, how long it takes sometimes to establish some practices.
And I really like the slide that Dr. Campbell put up with all the variation in practices and how long it took, and with various aspects of using vitamin A in our neonates. So great. To start off the discussion, like one of the audience question, I'll pick Dr. Poindexter for this one. As vitamin A is a fat-soluble vitamin, was vitamin A seen to be significantly beneficial in neonates born at the same gestational age but lower birth weight? However, we also know that infants born at lower birth weight for that gestational age are at higher risk of developing BPD. So do you think that would have been something to look at more closely, or what are your thoughts on that, Dr. Poindexter?
So, Sai, if I understand your question, are you sort of talking about maybe a sensitivity analysis to see which patients would have been more likely to benefit from the intervention?
More from a body fat content standpoint, like babies with smaller birth weight at that gestational age, as vitamin A is a fat soluble vitamin, do they see less response from it? Was that the question? Yeah, that was the question.
I guess I would probably think more about the more premature babies having more of that disruption of in utero placental transfer. I don't know that I've really ever thought about it in terms of body fat percentage.
And just to piggyback on that, Dr. Poindexter, has anyone looked at comparison of vitamin A levels in donor breast milk in comparison to maternal breast milk? We do know that the hind milk and colostrum has higher content, but like more often than not, we see our babies getting donor breast milk in our units in current days and current practices. Has anyone looked at the levels of vitamin A at all?
I'm sure that people have looked at it. I can't recall any, major significant differences. And I don't think that vitamin A is something that is tremendously impacted by pasteurization either. But John may correct me if I'm incorrect here.
I think you know that literature better than I do.
So I have a question for the moderators. So for the cost of the vitamin A, so I know it was under shortage and then it came back in, I think, 2014. So isn't the cost like much higher than what it originally used to be? And that was probably the reason that there was a low adoption because of the high cost currently?
I don't remember what the cost was when we did this trial. I remember vaguely that it was very low, like $15 or something like that for, I can't remember if it was $15 or $20 for the whole course or for a single injection. It was probably the bigger cost was the nurse's time and the syringes and stuff. But it certainly went up dramatically, and that contributed. So that was an issue. But I would also add, as long as I was singing Wally's praises, that Wally looked at using different doses, And we also looked at follow-up for babies at 2 years. And again, it wasn't statistically significant, but the direction, I think the relative risk for death or impairment was like 0.91 or something like that. So it was in the direction of greater neurodevelopmental impairment, lesser neurodevelopmental impairment. And if that's the case, the cost is probably a trivial consideration. I mean, let's say that Bayesian probability of benefit was 85 or 90% of reducing impairment at 2 years of age. Golly, that seems like a much more important consideration than what a cost that's maybe 1/10 of 1 day of neonatal ICU care or less. I think it's ridiculous that it costs that much, but it seems like it still should be a minor consideration compared to the possibility of the distress to the infant, the lasting pulmonary morbidity, the neurodevelopmental impairment associated with that, if it's potentially real. My question for Brenda or for y'all is, and maybe Dr. Campbell's go into this, is whether we need another trial or not. And if so, what kind of trial?
I would love to hear what some of the other fellow participants think.
I think another trial in the current era where the practices have like changed from when this trial was done would be great to even look at something like a bundle of interventions to decrease the BPD, and the bundle could include delivery room CPAP, like Dr. Carlo's trial and Dr. Tyson's trial with vitamin A, less invasive surfactant administration, non-invasive ventilation, and great nutrition support that we have currently. So maybe looking at all of them as a bundle and looking at outcome of BPD after that would be great. That was my thought.
But Sai, would you feel comfortable randomizing babies to not receiving vitamin A? So would you do this as a bundle of quality improvement, or would you actually give babies placebo versus vitamin A?
I would go more on the route of quality improvement bundle and trying to adhere to some of these practices, implementing one change at a time, looking back at them, and then like adding on to those changes. But as you rightly pointed out, a randomized trial would be almost unethical with some of these interventions showing significant benefit previously. So.
And I don't know, Meredith, did you share the slides with the enteral vitamin A versus BPD?
Yes, I have that as well. I was muted earlier, sorry. And kind of going back to John's questions before we address this article, kind of if I were to change the clinical trial again, I guess I would look at the primary outcome a little bit differently, because our definition of BPD, it seems like it's constantly changing. But I thought it would be neat to examine it with like ordinal regression instead. And so you could have infants at 36 weeks gestation who did not receive any oxygen at all, are on maybe nasal cannula, vapotherm, to, mild to more severe, to the extent where you're on mechanically ventilated at 36 weeks gestation. And analyze it that way.
We have.
You could comment a little bit on the choice of the composite outcome also, and understanding that babies who die before 36 weeks, really didn't have the opportunity to receive a diagnosis of BPD. But what I don't think we have sufficient detail is how many of the babies who died prior to 36 weeks died from a pulmonary complication.
Great, great. There's a couple of comments geared towards our learners in the chat box. This study really highlights the importance for our fellows and learners for reading the studies thoroughly and not just relying on conclusions, which are frequently sometimes biased by how the reviewers want them to be written. Another important point from Dr. Erica Edwards was Vermont-Oxford Network collects vitamin A data in 2019. 2,869 infants of 43,000 eligible VLBW infants received vitamin A, which is 6.6%. And of the 755 participating hospitals, only 155 reported that they've had an infant who received vitamin A. So still a moving target. That was a great presentation, Dr. Campbell, and fantastic review of the article in itself and literature surrounding it. I will let our faculty mentors have their final comments and final take-home messages from them to our learners, and then we will conclude this session. But while the final comments are being given, please take a look at the survey that I'll post in the chat box. We really value your feedback to make these sessions as educational as possible. So please fill out the survey at your convenience. Thank you. Dr. Poindexter.
Yeah, I mean, I think my comments would really be just to express the pride and enthusiasm that you all are embarking on this journey to review these papers. And I can't wait to see what this group, does in the future. And I hope that in reviewing these past trials that you all really generate those new ideas and hypotheses that can be studied moving forward. So this is, I think it's just phenomenal what you guys have put together. And guess it's, really a silver lining from the pandemic that, these kinds of forums are so accessible and, so successful. So thank you for having me be a part of it.
Dr. Carla.
Yeah, I'd like to start by thanking the group at Vanderbilt, Dr. Millie Stallman, Dr. Bob Cotton, and Dr. Chennai. They were pioneers on this. So the group at Vanderbilt it's a lot of credit. And John Tyson, who led this effort, and the Neonatal Research Network. And to the group, I would say also, we make a small improvements in care gradually. And we need to see how we can implement them. And obviously evidence changes, so we have to keep up with the evidence and keep making improvements in practice. Thank you. Thanks for having me be part of this.
Thanks, Dr. Carlo. Dr. Tyson.
Yeah, thank you. I feel like Brenda, and I hope that your generation will clean up and answer some of the questions that my generation has failed to do. I would encourage you, as you see, big clinical trials are important. They're going to be actually increasingly important, I think, as people begin to take more seriously the cutting edge in clinical trials, which is subgroup analysis, because it's very unlikely that the relative risk we get overall is the relative risk for all the important subgroups of patients. And really the cutting edge is to getting the data to better tailor it to the individual patient. And there will be, I'm sure, increasing opportunity to participate in multi-center trials at low cost. And as part of the learning healthcare system, that should be, our goal shouldn't be just to give care. That's not our clinical responsibility only, but also to be doing what's needed to do to improve care and outcomes. Thank you for having me.
Well, thank you so much, everyone, for joining. Dr. Campbell, excellent job, as most of the comments are echoing the same thing. Thank you so much. Thanks,
Thank you.
everyone.
Thank you. Bye-bye.
Bye.
Bye-bye.